So pre-op care for any cardiac surgery, we're not just talking about cabbages, so it could be any cardiac surgery. Your book does pretty good at describing all these. So our goal, we want to get them ready for surgery, right? They need to have the optimist health status. So we want to make sure they're as healthy as we can get them, okay? Stopping smoking. So that's a big thing. They have to stop smoking before it. Treat infections. What kind of infections do a lot of people have they don't even know? Women mostly. Anybody?
Like a UTI?
UTIs, mostly women will have a UTI, not realize it. So we're going to check, make sure. Do they have any infections? If so, it needs treated before we send them to surgery, right? So endocarditis, UTIs, pneumonia, even like MRSA, you know, or do they have any MRSA or phlebitis? If they have CHF, treat it as much as we can. You know, get them as good as they can be before we take them into surgery. Renal function, again, how is their kidneys doing? Blood sugar high, you know, we got to get it managed before we take them to surgery. Pulmonary function test, we're going to do ABGs, and they're going to do mapping of the legs. The person yesterday, Cassie can help talk about him. You know, they had trouble because they couldn't get good veins from his legs for his grafting. So we want to know how good, if for that surgery, how good is the vascular. So now we're going to do some medical management. So cardiac function, going to know what kind of arrhythmias they're having, right? Treat that arrhythmia. You know, of course, if they're going for a CABG, just because they've had the MI and they're blocked, so they're having arrhythmias, so we need to take care of that. The electrolytes, you know, we need to know how's their potassium, how's their sodium, all that. Renal and hepatic, of course, how is their kidney function, their liver function. Pulmonary, are they going to be able to handle a ventilator? You know, is this a 90-year-old person and they're wanting to send him to surgery, but pulmonary function is very low? He may not come off that vent, so he may not be a candidate for surgery. You know, and that's something that's going to have to be discussed. You know, every person's different. Labs, again, what's electrolytes, what's all their, you know, metabolic problems, you know, what's going on. Toxology, you know, have they been on drugs? You know, what's going on with that? And have they been on Coumadin? You know, we need to know. Fish oil, a lot of people don't think, but fish oil thins the blood. How many knew that? You know, that's not something you think. You know, we talk about when you're doing a mission assessment, don't just ask what is your prescription meds, what herbal meds or whatever are you on at home, because that plays a big part in any diagnosis. So if they say, oh, I'm on fish oil, well, they're going to have to be off of that probably a while before, because it will thin their blood. Are they on aspirin? You know, that keeps the platelets slippery, you know. So all this plays a part. So very rarely, you know, they do have a few that's an emergency, but usually it may be a day or two before they have this surgery, because they have to get all this, you know, the infections, the labs, the pulmonary, they have to get everything ready before they can take them. And sodium and fluid restriction, CHF, are they on the fluid restriction for that? Sodium needs to be low or what? So, and you as a nurse getting, you know, even on coronary step down or something, you know, they may be going to be having the surgery. So you're kind of helping them to get to this point. Pulmonary prep. So we're going to be putting them on the vent. So we want them to stop smoking, right? Afterwards, they need to learn how to use the incentive spirometer. We want them to stop smoking because it reduces the blood flow, which slows the healing. Surgical incision can get more infected because of the smoking. So we want to teach them to cough and deep breathe. Teach them how to use incentive spirometer. We're going to teach them about the ET tube. When they wake up, this is what you're going to have. Bella, tell him what your guy was doing when he woke up. You know, he was waking up and he had that tube in.
He was tapping his fingers, he was awake right when he got up to the unit, so he was very fast to get him extubated. So.
And how many hours was it? Do you remember about from time?
I was gonna say like maybe 4 at the most. It was very short.
Yeah. So I mean, I would feel the same way. I wake up and there's this tube, you can't breathe, you know, and you're like, get this out of me. You know, I think all of us would be that way. So, but so they need to be taught before they go, okay, you're going to wake up and you're going to have this in there. You know, we can't pull it right out. We have to do your blood gases. We have to make sure you're ready, you know. So this is all pulmonary prep, the teaching of all this. So sternal splitting. So when they go after the surgery, when they get them up walking, they usually give them like a heart pillow. They're going to hold that against them anytime they cough, anytime they walk. Okay, so that's another big, you know, when they go home, we'll talk about a little bit more about that. I'll explain that. So again, we want to minimize any post-op infection risks now. So eliminate chronic infections. There again, ear, skin, urinary. You know, something's going on. We got to get that taken care of so it doesn't pop back up later, right, after the surgery. Skin prep, they're going to have their CHG showers. Why wouldn't we want them to shave before they come in? Say, it's, you know, they come in that morning, they say, oh, I shaved. What's going to happen?
They could get an infection.
Right. And they have, when the nurse practitioner used to talk about this, they have canceled a surgery because the patient shaved that morning. So very big. Do not let them shave because any little point an infection can go into. So, you know, a bacteria can get into and start the infection. Prophylactic antibiotics. Usually they're going to hang those right as they get started in surgery or right before they go. Timely removal of lines. So any lines, their chest tubes, their Foley, anything invasive, the goal is 48 hours after the surgery. So 48 hours, we expect those lines to come out. You know, there is times it's not going to happen. They're still putting too much out their chest tube or this or that. But that's the goal. We want those lines out in 48 hours. So psychological prep, right? So we need to know, do they have good coping support systems? Prepare them again for the ICU, what's going to happen afterwards. They're going to be extubated that afternoon after their surgery. A lot of times they get them up in the chair. They'll be walking the next day, you know, let them know. Which I don't think I explained to the girls yesterday. That room they was in when they come back with the cabbage, they stay in that till they're discharged. That is their own room they have. They do not switch. So show the patient and the family all the devices that's going to be used. Ohio Health's really good. I don't know if any of you have got to do that when you're there, about the teaching. They show the videos to the patients and the families of, you know, what's going to happen. They may get blood, you know, this and that, to get them ready. My brother-in-law had his cabbage in Huntington, West Virginia, and it was supposed to be a heart hospital. No teaching whatsoever. I was the one that told him what was going to be coming. You know, it's sad. There's supposed to be a heart hospital, and the doctor just came in, drew on his whiteboard what he was going to do, and that was it. That's very sad. Surgeon, he should have explained the procedure, the complications, and the recovery. Anesthesiologist will, of course, explain about the tube, where they're going to put them out, how the recovery is going to go with that. Of course, you're going to have informed consents, and then discharge plans. So they're going to already remember, when you admit somebody, you're already starting to plan for discharge. So in this case, social worker is already planning, because if they do not have anybody at home, they have to go to a nursing home because they cannot be alone for 2 whole weeks. Why do you think that is?
They have like the lifting restrictions. They wouldn't be able to take care of themselves.
Right. They have the lifting. They'll have the pillow. If they don't have like a lift chair or recliner or something, they may not be able to get up by themselves, you know, so that it's a very, when I did home health, I did a lot of these visits with these open heart patients. My own brother-in-law had to go to a nursing home after his because his wife was already in a nursing home, so there was nobody to stay with him 24/7. It has to be 24/7 for 2 weeks. So as soon as these patients come in and they start planning the surgery, the social worker is already planning where is he going after this. So diagnostic studies, cardiac workup. So of course our EKG, we're going to have the echo that's going to show from last week. Who could tell me what's the main artery that has the most blockage? Yeah, come on.
Is it left anterior?
Left anterior descending, the LAD, also called the widowmaker. So this is the majority of the ones they're going to see. That's where it's at. Now there may get some of the others, and they may have more than one blockage, but just remember LAD. Yep. So again, the echo is going to show all that. Cardiac enzymes. What's our cardiac enzymes? Let me pick on somebody here. I know you guys probably. I ain't studied yet. Morgan Smith. What's our cardiac enzymes?
Troponin, myoglobin.
Mm-hmm. And then we have the CPK too, or yeah. But troponin, myoglobin's your main ones you want to pay attention to. So those are probably going to be increased, of course. And then the catheterization, that's going to show them where the occlusion's at, of course. So good. Common cardiac surgeries, we're going to go over each of these. Ejection fracture. What's a good ejection fracture for anybody?
Like around 60%.
60. That's what we're aiming for. Some people, depending on their comorbidities, 40 is okay, but 60 is the good ones. Good. So let's go into each of these in just a minute. So I have a little video of our open heart. So let me stop share that. Share this.
And the bone is the sternum, which will expose for you. Now, when we pull the bone, we use a sternal saw to cut the sternum. Like that, okay? Mm-hmm. So after we cut the sternum, we have to access to the mediastinum. Have to stop the bleeding now, which is minimal. This is the periosteum, the edges of the bone that is oozing, and we'll stop it real quickly. Okay, now we are using a special retractor which is going to lift up the left side of the chest bone so we can harvest the left inferior mammary artery. The left inferior mammary artery is starting from the left subclavian artery and goes down behind the chest bone all the way.
You see the guy down here at the end is taking the artery from the leg that they're going to use on the graft. So
To the abdomen, towards the groin. This is the best graft that human body gives us, and the patency of the graft is 95% in 20 years. This is the only time that surgeon sits during heart surgery to harvest the vessel. So this is the left chest. This is the pleura. You can see the lung. That's the lung. These are the ribs. So the vessel is running somewhere here, which we'll be identifying and starting to harvest soon. Thank you. Thank you. Okay, you can see the vessel here running behind the sternum. This is the left inferior mammary artery. Now there are multiple branches which are going from the vessel left inferior mammary artery to the muscles and bone. So we have carefully identify the branches and cut them or clip them. That's what we are doing now. The vessel is here. We are taking the vessel off the chest wall, and meanwhile, clipping and cutting the branches. Meanwhile, also Tom is harvesting the vein. So now we are going to give heparin, which is a blood thinner. We have to make this blood watery so it will not coagulate, because we are going to put tubes into the vessels and reroute this blood from the body to the heart lung machine. So now what we are going to do, you can see this is the vessel that was running behind the chest wall. Now the vessel is out. We are going to disconnect this vessel distally. Now this is the vessel. It starts from the subclavian artery from the left side, and we're going to connect this vessel to the coronary artery. You can see the flow, the blood flow through it. So we are opening the pericardium now. Pericardium is a fibrous sac which covers the heart. You can see this is the pericardium, heart beating, and this is the diaphragm here. Now we are going to cannulate the aorta, which means we're going to put purse-sling sutures on the aorta and put tube in and tighten the sutures so the blood will not come out from aorta. And we're going to connect the tubes to the heart-lung machine. So this way we can take the blood from the body, get back to heart-lung machine, get it oxygenated, and then give back to body so we can start the heart. Basically, the heart-lung machine functions as heart and lung. So this is the aortic cannula. What we do, we put this inside the aorta like this. We tighten the purse strings, and we're gonna take the blood from the right side, give it to the heart-lung machine. Heart-lung machine is gonna get the blood oxygenated, and we'll push the blood through this cannula into the aorta. So patient's body will get the blood flow while the heart is stopped. Okay, we're gonna put this in. We have to take the whole air off because we can't give any air to this line. It will cause stroke. You can see the flow to the aorta now. With the air, the cannula. Come up. Now we are putting the cannula into the right atrium and inferior vena cava. This is the cannula, big venous cannula. We're going to take the blood through this cannula and then give it to the heart lung machine. Okay, so this is the paraplegia line. We connect it to the antegrade paraplegia cannula and retrograde. What we are doing, we are giving a special solution to this, which has high potassium in it. That's what stops the heart. And every 15 minutes, we have to feed the heart with the blood and nutrients and oxygen. So every 15 minutes, we are giving the paraplegia to keep heart cold and well fed. This is the temperature probe. We are monitoring the temperature of the heart muscle. We like to keep anywhere between 14 to 2021. So this is the left greater saphenous vein, which we harvested from the left lower extremity from there with the help of scope. And we're going to use this as a graft. Again, we're going to connect this to the aorta and distal to the lesion. Okay? Right now, what we're going to do, we are going to stop the heart. We are giving solution rich with potassium that will help us to stop the heart. We'll do it right now in 2 seconds. So the potassium-rich cold solution is going right now into the aorta and towards the heart. Heart will stop now. Okay, so we're measuring the temperature in the heart with this. Okay, you can see heart stop. You can show the EKG if you want to. It's a flat line now, the green, so there's no cardiac activity. The 22.1, the white color, it shows the temperature of the heart, 21.7 and going down. The 76 in the red color shows the blood pressure, which is generated by heart-lung machine of the heart. So we are trying to identify the vessels and open it up. This is the diagonal artery, which is really small, 1 millimeter. Okay. So the vessel we are showing is 1 millimeter in diameter, really, really tiny. Yeah. Let's see the flow now to the graph. Well, then let's see. We are showing the anastomosis now, the left inferior mammary artery to left anterior descending coronary artery. This is now one of the main and important arteries we are bypassing. They call it widowmaker. So now what we are doing, we are giving warm blood to the heart so we can warm it up and get rid of the potassium. Okay, so heart's gonna start beating now or fibrillating. We also put a pacing wire in case that the heart rate is will be slow, then we can pace from outside. This is the pacing wire, goes into the heart. And comes out the skin. Start pacing, please. Put it on. Okay, so we are pacing the heart now. You can see the electrical stimulus comes through this wire into the heart and heart starts to beat. Wait, whenever you're ready. Ready? Okay, slow down. Movement up. So now what we are doing, we are taking out everything that we put previously in. You can see the heart is now in fibrillate ventricular tachyarrhythmia. So we're gonna defibrillate it. Then pressure off. Thank you. Okay. You can see it regain the regular rate again. Pretty good rate now, in fact. Move forward. So now what we are doing, we have to put two holes about a half a centimeter in diameter in the aorta, so we can suture the proximal part of the vein to the aorta. Okay. You can see now these are the graphs. Can you see the graph there? Yeah, this goes to the diagonal artery, this goes to the occlusal marginal behind the heart, and this is the other graph, left intermammary artery to left lateral descending. Inside the lungs expanding. The blood is still watery, so we're going to give protamine reverse to heparin, and then you'll see it's going to dry up very fast. Hearing, where you want to come on? Temperature. Now we're going to put these tubes in. It's going to drain the residual blood and fluid from the chest for a couple of days, then we're going to take it out. This one, okay. Now we are using this wires to bring the serum together. We use usually 8 wires. Yeah, so
So there you have it. All right. So as we talk about on pump and off pump, I am not going to quiz you on this is what they do during the, just be aware, you may have that question in CLEX, I don't know, but just be aware there is on pump and off pump. On average, a surgery 3 or 4 hours. Bella, would you say that's about how long you was in there when you got to watch it?
Yeah, I'd say so. Yeah.
Yeah. Now, did you get to see it this close?
Oh, I was right by the anesthesiologist, so I just remember the smell when they were doing the draw. I was like, oh my God, like I will never forget that.
Yeah, that's pretty good. Pretty intense, that's for sure. I'm glad they know what they're doing. If you like OR, that's eventually something you may be in. The one guy that was in it yesterday, I actually went to RN school with, he worked his way up ICU and he worked cath lab. Now he does mainly the open heart OR. So, it's just something you may like. So, let's see. Things we're going to consider again for any cardiac surgery is age. Doesn't mean a 90-year-old won't have it. They have had them as high as 90 and as young as 18 as far as adults go. But if they have a lot of comorbidities, COPD, diabetes, cancer, they may not qualify for it. And again, we talked about the pulmonary function. Should they have it? Because they may not come off that bed. So we need to make sure we understand all that. And again, there's our left anterior descending artery. Remember, that's left coronary, left anterior descending. That's where you're going to see the majority of the occlusions. What do we call 100% occlusion? Anybody? STEMI, good. See, I'm quizzing you already. Don't forget to do your discussion. Did everybody see that? Where you can put in a question. If it gets picked, you get extra points on the test. And plus, if you read everybody's, that'll help you be able to answer that question. So here's some pictures. Anymore, they barely will have a big incision like this. It's usually maybe an inch, if that. I mean, they've really come a long way. When they use these, if they use the whole leg, they would come to here and like stop and then start again below the knee because of the movement of the knee. And he talked how they use the mammary gland artery and also the vein in the leg. Here's just a few of the pictures. The most pain, there's the one I tell you where they stop at, but anymore they just have a little incision. The most pain these patients are going to have after, you would think it would be this incision. It is not. I can't even think, maybe Bella can remember what they said they used to deaden the nerves in here, that they don't have that pain. Their most pain is from their drain sites. They'll go home and they'll usually just have Percocet for a while and that's it. They do really good. It's amazing. So again, we said off pump and on pump. So they may use the heart and lung machine. They may not. Just another picture of that I think I had of the off pump. And there's when they're on the pump, he talked about how he was taking these into the aorta. Another picture of a surgery. Like you see the harvesting leg there and they're working up there. Usually this person here is a nurse practitioner or PA or, that is helping with the surgeons. So, and there's our machine back there. Picture of what happens with the cabbage. So here's where the flow is blocked. See, the plaque is blocking it. So then they're going to take that graft and they're going to go around it. See how they go above and below it. See, there's another one there because they had a blockage there. So I'm so glad they're so smart to be able to do that. This is actually on an autopsy, and you can still see the pacer wires. Remember how he talked about the pacer wires? So there it still is. This guy's proud of his scars there. So this one here, this can happen. Look how bad that, like dehisced. Look where they put it right in the bend of that knee. Why they would do that, I don't know, but you see where it opened up. I know in home health, I checked on a patient. He was diabetic. His was getting pretty red and angry, as they call it. I had to call. He had to go back in. So, you know, diabetes is they're very careful about trying to control them so this doesn't happen. A couple of times the wounds have dehisced, the actual incision. So now a few post-op complications. So the heart needs to restart, right? And seen how they gave him the potassium to stop the heart, the cold potassium. Heparin, that gets protanamine sulfate. Do you know, this is just a trivia, certain men cannot have protanamine sulfate. Do you know? Any idea why they couldn't? Any guesses? You'll probably never guess it. I would have not either. So any men that's had vasectomies, the protanamine sulfate is actually derived from fish sperm. So something about the vasectomy and the fish sperm interacts, so they cannot use that. So think of that, you know, when you're getting your patient ready, you know, hey, have you had a vasectomy? So they may need to know that for the surgeon. Not everybody would have a problem, but possibly. And again, they're going to be on the ventilator. So some things as nursing, you know, you want to watch. Hypotension, they've lost that fluid volume, right? Maybe it's from meds, maybe from blood loss. The guy yesterday, they was going to start 2 units of platelets on him. I don't know if he got blood or not. Cassie, did he get blood yesterday too, or just platelets?
He came back from the OR with blood running.
That's right, it was running, and then they gave him platelets. That's right. Hypertension, it could be from the stress of the procedure, could cause stress on the sutures. You know, they're going to have the art line and continuously watching that blood pressure so they can adjust the meds. You know, they've got the other lines all in. So, hypothermia, what was his temp? You said they had to have him on the warming blanket?
He was like in the 95s.
Yeah. So a lot of times they'll come back with the bear huggers or warming blankets you'll see on them. And then hyperthermia, of course, you know, metabolism and the oxygen need. So any complications can cause shock, right? So the bleeding, you know, we've got the heparin reversal, the hypothermia. Surgical bleeding can be oozing. They can cause cardiac tamponade. Like I try to tell you when I take you through there, they practice drills in that unit in case they have to open them back up at bedside. They said it has happened once or twice. You know, they try to get them back to OR, but sometimes it's just not possible and they have to do it right there. So they do have their drills where they practice how it can be done. So that's good, you know, they can practice that. So. Okay, so valve replacements. Here's your aortic valve replacement. So they do these pretty, it's so easy now, seems like 94% for 5-year survival after these. It depends, of course, what's their overall health. Are they in good health before they had to have this otherwise? So that's aortic valve. There's a new procedure for it called a TAVR, transcatheter aortic valve replacement. So you see it right there. Incision is made in the chest to remove the unhealthy valve. A catheter is implanted. Implant a new valve within your diseased valve, and it can be done even through an incision in the leg. So they can go up that way and do this. So it's lower instances of death, stroke, and rehospitalization compared to open heart surgery. So they're inventing new ways to get away from, you know, breaking up open those ribs and stuff and trying to do this. So mitral valve repair and replacement. You can see it on the x-ray where she has the mitral valve in there. Big thing about this is if it's a tissue replacement, you're only looking at like 15 years. Maybe they'll get out of it. If it's mechanical, they're going to have it a long time, but they're going to have to be on lifelong Coumadin. So, it's like I'm sure it depends on them also and the doctor deciding which one's better for them. Do you want to be Coumadin all your life and have to do your blood work all the time? Or do you want to try the tissue? So mechanical, lifelong Coumadin, tissue, it's a 15-year lifespan.
Be Coumadin. Does it have to be Coumadin that they're on, or can they be on something else?
I'm thinking it's going to be Coumadin. I guess I need a little bit of research on that, but just know it's going to be some kind of blood thinner lifelong. So,
Okay.
yeah. Yeah, I'll have to look that up. That's a good question because they may have, I just know when she came and taught us all this stuff years ago, the one that would go into these surgeries, she said it had to be lifelong Coumadin. But with all these new ones, maybe one of them would work and it wouldn't be as bad because they wouldn't need their blood work. So good question. Yeah, I would definitely look that up for you. So, they're learning again all different ways to get these implanted, less stress on the patient, less recovery time. This is called a bioprosthetic. This is made of cow or pig tissue. Again, they don't need the lifelong blood thinning medication, so a lower risk of bleeding for them. I'm just showing you different ones. I'm not going to quiz you on these. Prosthetic ball and cage valve. So you see how it looks just like a ball in a cage. Now this one, depending on the age, it may need change as the individual grows. So I don't know that I would want to attempt that one, all right? Something you won't see at Ohio Health, they do these at Cleveland Clinic. It's a heart transplant. And what happens usually is they add the new one to the old heart. So, did you talk much about peds in the heart transplant? Did you talk much about that in the cardiovascular part?
A little bit about being on
I thought you did, and that'll change as it grows. My husband had a nephew, he had a transplant at age 11. It lasted 19 years. He was on the donor list for another heart and kidney, and he coded and passed away at age 40. So, they only last, unfortunately, not real long. So. Okay, we talked a little bit about the VAD when we watched Andrew, the fitness model that had his and showed how he used his and all that. So mainly acute left ventricular failure prevents the acute pulmonary edema. And they have no pulse, it's continuous flow. Intra-aortic balloon pump, Mary talked a little bit about this. They got to see the one in the ICU that day. So this decreases cardiac workloads. That's the one thing you want to always remember. They're putting these in to decrease cardiac workload. You can see how the balloon blows up there inside. Okay, nursing care. So you are going to assess your patient, right? You're going to protect and assess that airway. Make sure he's hooked up to monitors, connect the chest, check the chest tubes. He'll have usually 4 chest tubes, sometimes 3, usually 4. 2 is in the pleural space and 2 in the mediastinal. As soon as he got back that room, they did a chest x-ray yesterday, and we got to see the different wires where everything was going and his sternal wires. Labs, ABGs. Like I said, in the open heart, when they have the cabbage, for a while it's 2 nurses to 1, and then it's one-on-one for at least a good day. So they're very, very watched, and the orientation is very intense. Okay, so pulmonary. So we're going to do your cardiac assessment. We've talked about cardiac assessment. So pulmonary, we're going to know they're going to come off the vent when they're ABGs. Those of you that's in the room, do you remember how many times they drew ABGs when they came back? Cassie or Bella, do you remember?
I got it twice.
Twice, okay. And when they come back, respiratory, they're usually in there pretty much nonstop for a while also. So they're going to check those ABGs to see when they can be extubated. So, neuro, are they conscious? Like Bella talked about her guy hitting the side of the rail. You know, he was conscious. He would do what they told him. You know, so is their neuro outlook good? Fluid volume, is it adequate? We talked about the CVP line last week, right? We want to know, is it between the numbers it should be? Is the fluid volume good? And that's all those monitors, that's what they're watching. The renal function, if you notice when we took you through yesterday, I showed the girls on the Foley catheter, it's an hourly output meter, I think they call it on there. You know, so they can really watch. Are they putting on enough urine? Blood sugar, again, a lot of times they're going to be on insulin drips after any of these surgeries. So we need to know that blood sugar. How often did they do it? Every hour, I think they said in there?
Yeah, I did it every hour.
Yes. I was going to say, I thought you was the one that did that. So we really need to keep ahead of that. And then again, the pain. Like I said, they're going to have pain at first, of course, from everything going on. But then eventually, the pain is not very bad at all. And most of them will tell you. Worst pain was where they took it out of my leg or the drain site, you know, so. But that doesn't mean they should be able, you know, they should go right back to doing what they used to do. She talked about they had a guy in his 40s maybe, and like within 3 weeks he was riding his motorcycle. Well, what happened? He ended up laying it down, wrecking. So what's he do? He picks it up and pops all his sternal wires. I was like, no. You know, so they got to realize they may feel good, but you cannot do that.
If they're just coming back from having surgery, a way to tell if they're having pain, would you just go off their vitals, like if their heart rate was elevated?
Pretty much, Cassie or Bella, could you tell, or did the patient tell you, or?
Since my guy he was awake, we asked him and he would shake his head yes. And so we ended up giving him Tylenol IV to help with his pain.
Oh, okay. Yeah. Because you don't want to like give morphine maybe and sedate them too much, you know. So there's again that fine line, and the nurses in there, they know exactly what they need to do it's up to them to titrate those meds, right? So you know, you don't call the doctor each time. That is up to them to take care of. So good. So yeah, the ones that, and you're right, vitals will show it, you know, different things will show if they're having pain, if they can't tell you, just like any inpatient in the units, right, that are intubated or whatever. Medication, so often after surgery, you're going to have what's called polypharmacology. So a lot of meds, they're going to be reintroduced only if appropriate. So do they still need the antihypertensives? Do they still need the renal? Do they still need the diabetic parts? Maybe they need diabetic education, inhalers, respiratory things, right? The big thing about these patients when they go home, they are told the only doctor they will see post-op for 6 weeks is this heart doctor. They do not go back to the family doctor yet because the heart doctor wants to know what they're on, wants to make sure what they're doing. If they go to the family doctor and something gets changed, and that's going to maybe mess up what's going on with their healing. So they do not go back to the family doctor for at least 6 weeks. Again, they may be on aspirin, Coumadin, beta blockers, ACE inhibitors, maybe on the statins, the fish oil, right? Discharge teaching, of course, call. They want them to monitor their blood pressure and pulse, their daily weight, edema, you know, they want to know things are changing. And this is where I said, if they go home, they're going to have home health. That goes in there. I used to take even students with me when I was in home health, and they would take the sutures out or the staples out of the incisions, you know. So home health is there to watch, you know, to make sure things are going okay. They need to walk. They need to use their incentive spirometry. They need to go to all the appointments that get scheduled before they're discharged. They want them to start the cardiac rehab when they're allowed. Again, family CPR. No smoking, no alcohol, right? Okay, now we got some questions. When preparing a patient for discharge after surgery, you should teach a client that there will be Brittany Smith, no further drainage from the incision, a mild fever and extreme fatigue, little incision pain and tenderness, or increased edema in the leg. What do you think? Just a good guess. I know these are a little bit hard. Are you driving? Okay.
No, maybe C.
Okay. Anybody else have an idea? I know it's a little bit. It's actually going to be D. Not that C is not bad, but once they start increased activity, that leg is going to get a little bit more edematous, maybe. So that's going to be normal, but if it gets huge, you know, there's problems then. So you need to teach them what to watch for. Arteriosclerosis impairs coronary blood flow by which of the following? Who can I pick on this time? Ella. What do you think? Do they classic obstruct the vein, the artery, blood clots from outside the vessel wall, or hardened vessels dilate?
Is it B?
You're right. It is B. Classic obstruct the artery. Good. Client has been admitted to the hospital, diagnosed suspected bacterial endocarditis. I'll run through that. And complication nurse were consistently observed for is Abby. Presence of heart murmur, systemic emboli, fever, or CHF.
Fever.
Anybody else?
CHF. I don't know.
It's actually systemic emboli. So they arise in the right heart chambers, can be in the lungs, and can travel anywhere. So heart murmurs, fever, and night sweats may be present, but do not indicate a problem of emboli. So emboli is what they're always watching for. Good guess. The nurse expects a client with mitral stenosis would demonstrate symptoms with congestion in the, let's see, who can I pick? Michele. Aorta, right atrium, superior vena cava, or pulmonary circulation.
Is it mitral or pulmonary circulation?
Right, good, because of mitral stenosis, pulmonary circulation. Good. See, you know more than you think. Which are found signs and symptoms most likely to be found in a client with mitral regurgitation? Misty, exertional dyspnea, confusion, elevated creatinine, chest pain. Anybody want to guess?
Exertional dyspnea.
Yep, that's it. Because the left atrium has difficulty emptying its contents in the left ventricle, so no valve to prevent backward flow into the pulmonary vein. So the pulmonary circulation is under pressure. Good job. Okay, let's take a 10-minute break, and we'll